Entonces, con mucho cariño de parte de todo el equipo del instituto, de los asistentes, tengo un pequeño discurso para il doctor. ¿Sí? Stimato dottor Fogazzi, a nome dell'Istituto del Perù, le do il benvenuto alla parte conclusiva di queste conferenze effettuate nel mese di novembre di questo anno. È importante per noi, come colleghi di la presenza di referenti internazionali, la cui partecipazione dà un valore molto agli insegnanti delle temi relativi all'analisi dell'urina. È necessario ricordare che l'interesse del Collegio Latinoamericano cresce anno dopo anno, poiché l'Istituto di Perù, così come altre scuole di Messico, Ecuador, Colombia, Brasile, sta unendo le forze per facilitare la comprensione di quest'area della sanità alle nuove generazioni che hanno fame di conoscenza. Non mi rimane che ringraziarla nuovamente per averci accompagnato e per aver concluso col suo corso, questo corso internazionale di conferenza sull'analisi dell'urina. Con molta stima, suo amico e ammiratore Eduardo. Grazie.
Okay. Okay, thank you very much, Eduardo, for your nice and kind introduction. I'm Dr. Fogazzi. I am a kidney doctor working in Milano, and I am the responsible of a clinical research lab on urinary sediment, okay? And I will speak this evening about urinary crystals. Next slide, please. Crystals are one of the several categories of particles which can be seen in the urine. And next slide. Next. And quite interestingly, the crystals were the first particles seen with a microscope in the urine. This happened in France in 1630. And the particles which were seen with the microscope were crystals, a heap of rhomboidal bricks of irregular shape. And the person who saw the crystals for the first time in the history of medicine was a French scientist called Nicolaus Claudius Fabricius de Peyresque. Next slide. But not only that, the crystals were the first particles which were represented by images concerning urine. This happened in 1665 in England, and the image, next slide. This is the first image of urinary sediment particles, and as you can see, it's again made of crystals. And this image was published in a very important book in the history of medicine, which is called Micrographia, which was published by a very famous scientist working in the United Kingdom, the name of whom was Robert Hooke. Next slide. Now, what do we know about crystals today? So we did a very short historical introduction, and now we are in our days. So crystals in the urine, there are many types. They show a wide spectrum of morphologies and of clinical, and also the different types of crystals may have different clinical meanings. First questions and first very important point is how to identify crystals in the urine sediment. Next slide. In order to be able to identify in a correct way the crystals in the urine, it is important to have to know three features of the particles themselves and of the urine. The features concerning the particles are: one must know the commonest morphologies of the most frequent crystals. If you don't know the commonest morphologies, you cannot do anything. The second important feature is the birefringence the crystals have under polarized light. And the third important feature, which allows us to identify the common crystals in a very simple way, is the knowledge of urinary pH. Once we have these three features together, morphology, birefringence under polarized light, and urinary pH, we have to match these three features, and on the basis of the matching, we can say this crystal belongs to this category or to another category. Next slide, please. And what about morphology? Morphology is obtained by knowledge, so one has to study if he wants to have a correct approach to urine microscopy and to urinary crystals. And besides knowledge, also experience is mandatory, of course. So this is the basis. In addition, what is really necessary is the availability of an adequate microscope. And the microscope the adequate microscope for the examination of urine sediment is a bright field or phase contrast microscope equipped with a low magnification, 100 pair or 200 pair, and a high magnification, 400 pair. And I stress, and polarized light. If you don't have polarized light, your approach to the identification of crystals is not adequate. Next slide, please. I mentioned in my previous slide phase contrast microscope. Phase contrast microscope is the type of microscopy which is recommended by international guidelines for the examination of the urine sediment. It allows a better identification of particles with low refractive index, such as ghost red blood cells, which are erythrocytes with a reduced hemoglobin content, and iron casts. In addition, phase contrast microscopy enables a better identification of the morphological details of red blood cells, epithelial cells, and casts found in urine sediment. However, next slide, please. However, for crystals, phase contrast, of course, is really an adequate instrument. But next, please, can you, okay. But as you can see on the right part of the image, we have on the left phase contrast and on the right bright field image. These crystals can be very easily identified with both types of microscopy. However, bright field microscopy on the right side of the image show, compared to phase contrast, the morphology, the structure of the crystals in a better way. So as a general rule, phase contrast is superior to bright field for a number of particles, but for crystals, at times bright field can be better. Next slide. As you can also see in this image, on the left, we have an unusual type of uric acid crystal, the morphology of which, the three-dimensional structure of which is better seen with bright field. Next slide. And now, after having seen the basis for phase and contrast bright field microscopy, now polarized light. Polarized light is based on the use of two filters, one which is under the condenser and the other one which is over the condenser. And to use them, you have to rotate one on the other one. And if the particle is a particle birefringent, you will see that it is shining, brilliant. compared to the dark background. Next slide, please. And these are the components of the polarized light. We have a component A, which is one which is above the, can you, next slide, please? Okay, we have B, which is filter, which is below the condenser, and A, which is above the objective. And you, in order to obtain polarization, you have to rotate the filter B, okay? And with rotation, if the particle is B refringent, you will see a shining structure, okay? And what is really important to know and to accept is that you cannot identify in an adequate way, in a correct way, crystals if you don't have polarized light, the filters for polarized light. Next slide, please. Unfortunately, the reality is that still nowadays, only a minority of clinical laboratories have microscopes which are used for urinary sediment examination equipped with polarized light, which is a simple device to be used, and it is also inexpensive. So if you have your microscope, which you use for the examination of urine sediments, you don't have polarized light, you don't have the adequate instrumentation to evaluate and to identify crystals. This must be clear. The other important thing is that the purchase of polarized light filters is not expensive. It may cost you 100, 200, 300, 400 euros, no more than that. So please, if you don't have polarized light, first, accept the idea that your equipment is not adequate for the identification of crystals, and two, that you can buy it at a low cost. Okay, we can go on now. Next one, please. Okay, the third feature which is mandatory for the identification of crystals is the knowledge of the pH of the urine. As you can see here, this is a table which we have published, which is contained in a paper which is published in 2011, which describes our experience on urinary crystals in our everyday work. And you can see on the right, here on the right part, in the right side of the slide, of the table, that the different types of crystals, which will I describe in a few seconds, in a few minutes, all of them may be found in different ranges of pH. Next slide, please. So what is important is to have the adequate microscope, which means bright or phase contrast microscope, plus polarized light, plus the knowledge of pH. Once you have the possibility of matching morphology with the birefringent features with pH, you will have the possibility to identify the most part of the crystals you come across in everyday practice. However, sometimes crystals appear with unusual morphologies, and in that case, it is difficult to identify them based only on morphology, birefringent features, and pH. When this happens, you have two possibilities. One is to know the solubility features of some crystals. When solubility, which means that the possibility to dissolve them when the urine is containing those crystals is exposed to heat or to acidic or basic substances or to alcohol. Just to give you an example of a crystal or types of crystals we identified by the means of solubility features, I give you an example of amoxicillin, which is the last crystal in the list that you can see on the left side of the table. In that case, which we published in 2018 together with a group working, a nephrological group working active in Switzerland, we were able to identify amoxicillin crystals by investigating the solubility features of these crystals, exposing the urine to heat and different acidic and alkaline substances. And you see that we could identify those crystals as amoxicillin because they were insoluble when exposed to heat and to a basic substance, and insoluble, and while they were soluble when exposed to acidic chloride acid and to alkaline substance with a pH of 8. Okay, but these solubility features, they are reported in all textbooks and in all atlases devoted to urine. However, this test is very rarely performed. Another possibility, next slide, to identify crystals which arrive with, next slide please, which arrive with unusual morphologies, or for which the matching of morphology, the reference features, pH do not work, is to use infrared spectroscopy. However, infrared spectroscopy is the gold standard to identify the uncommon crystals. The problem is that infrared spectroscopy is an advanced technology which is not available in all laboratories. For instance, we too don't have the possibility to perform infrared spectroscopy when we come across unusual crystals. But however, we have the possibility to filter our samples in those cases and to send the samples to a very specialized lab in Paris, which is the crystal lab, in which the most expert in the identification of crystal is Professor Michel Dodon. Next slide, please. Okay, and this is how we prepare our samples when we have the necessity to investigate the samples with infrared spectroscopy. And it is a very simple technique. We centrifuge our sample in the common way. Then we filter the sediment with a special filter, which is Wattmann 542, and left to dry the filter overnight at room temperature. Then the dry sediment is removed from the filter with a lancet, and it is then examined by infrared spectroscopy. Infrared spectroscopy, I repeat, is the technique which is mandatory for the identification of unusual crystals. The true problem is that it is not available in the vast majority of labs. But what we can do is to get in touch, to create a collaboration with specialized laboratories, as we have been doing for 20 years now with the crystal labs in Paris, directed by Professor Dodon. Next slide, please. Okay, before starting speaking about our classification of crystals, I would like to know if you have questions. If you have questions, I can answer and we can go on. Do you have questions? Okay.
Estimada, las preguntas los puede traducir del chat, por favor, para el profesor, si hubiese alguna.
No question. Okay. So our classification of crystals. So usually in textbooks, for instance, in the textbook on body fluids and urinalysis by Professor Nancy Brunzell, or in the other important atlas, which is the atlas published by the College of American Pathologists, crystals are, I would say, classified on the basis of the pH. Our classification is done in some way different way, and we consider we distinguish crystals as common crystals, pathological crystals, rare crystals with uncertain clinical meaning, and crystals which are due to drugs. Let me start with common crystals. Next slide, please. Next. Okay. The common crystals in decreasing frequency in our lab are calcium oxalate, B-hydrate and monohydrate, uric acid, amorphous phosphates and urates, triple phosphate, and calcium phosphate. Okay? Next slide. So B-hydrate calcium oxalate, they can be found in urine pH in a wide spectrum of urine pH, ranging from 5 to 8, but in most cases in acidic urine, acid urine. In fact, our median is 5.5. This is based on our experience. Now, please go back. Okay, and here you can see that the most common morphological category of B-hydrated calcium oxalate crystals is B-pyramidal structures, as you can see very well here on the left. You see they are two pyramids, one over the other. And on the left side, you see their birefringent features. Birefringent feature. As you can see here, some crystals are very shining, birefringent, while other, for a reason which are not clear, they are not. The B-pyramidal shape is the most common morphology of B-hydrated calcium oxalate. However, next slide, we can have other morphologies, such as these, which are star-like appearances, okay? And at times, as you can see in the bottom part of the left, of the image on the left, we may have B-pyramidal crystals, which are, however, irregular compared to the one which we have seen in the previous slide. These for B-hydrated calcium oxalate. Next slide now. These are monohydrate calcium oxalate. Again, they can be seen in a rather wide spectrum of urinary pH, ranging in our experience from 5 to 7, with a median pH of 5.5, again, in most occasions in acid urine. Here we see crystals of monohydrate calcium oxalate, which have an ovoid or ovoidal shape with a central spot. On the left, we have bright field, on the right, we have birefringence, polarized light, and you can see very well that they are strongly birefringent structures. Next slide, please. Another morphological category of these B-hydrated calcium oxalate crystals is dumbbell shape. Here we have an image at a low magnification, 160, rather than 400 as in the previous ones. And you can see here the dumbbell shape, which can be seen very well in the upper part of the image on the left. And on the right, again, we see that they are very strongly birefringent. Beside ovoidal structure and dumbbell structures, next slide. Here there is something, let me see, I'm sorry, I have the, let me see. Okay, good. Then we have here another image, another morphological category of, okay. Okay, can you hear me? Catalina, can you hear me? Hello? I don't know what happens here. So we have another a morphological category of monohydrate calcium oxalate crystals, which are thin plates which have a slightly arched side. You see here, and again, some of them are very strongly birefringent, while others are less. Next slide, please. And now we go through uric acid crystals, which can be seen mostly in acid urine, the pH of which ranges from 5 to 6.5. But this 6.5 is, I would say, a bit doubtful. We have seen in some cases crystals resembling uric acid crystals which had a pH of 6.5. But you must consider that in our lab we use for the evaluation of urine pH dipstick, which is not as precise as a pH meter it is. Okay, so at this point we must know that uric acid crystals present the widest spectrum of morphologies, but in spite of the morphology they have, they are always strongly birefringent under polarized light. Not only strongly birefringent, but also polychromatic. Here we have on the left an image obtained with phase contrast microscope, which shows one of the commonest morphologies of uric acid, which is lozenges, okay, which can be present as individual particles or as aggregated particles, as you can see here. On the right side, we have those particles, all of them strongly birefringent and polychromatic. Next slide, please. Here we have another common shape of uric acid crystals, which is that of barrel. Unfortunately, we don't have polarized light image here. Another important thing that should be not forgotten is that uric acid crystals quite frequently have this yellowish color, which is useful, which can be used to, another feature which can be used to identify them. Next slide, please. And here we have some uric acid crystals which can appear as hexagon, more or less regular or more or less irregular. What is important is that all these crystals, they are, compared to other hexagonal crystals, as we will see in some minutes, they are always birefringent and polychromatic, as you can see in the lower part of the image. Next slide, please. But we may have very unusual morphologies of uric acid crystals, which are difficult even to define. So we have, for instance, this crystal with this very peculiar, you see, striated birefringence. We may have a diamond-like morphology, and here maybe you can see the yellowish color, which I mentioned before, as a typical feature of uric acid crystals. You see here again the strong birefringent features, birefringence under polarized light and polychromatic, as you can see in this part. And then another very unusual morphology of uric acid crystals with also a very unusual birefringent features. In addition, next slide, please. We can have pencil-like crystals, which are due to uric acid. And these, to identify these crystals, however, as uric acid, we had to perform infrared spectroscopy in a specialized lab in Rome. And we published these crystals 2 or 3 years ago in Clinica Chimica Acta. So we don't have to forget that urinary acid crystals can even appear as pencil-like structures. But not only that, next slide. We can even have very unusual morphologies of uric acid, as they are shown in this image. In these images, we called these crystals grenades, which because they are similar to the grenades which are used during the First World War. And for the first time in the history of medicine, we were able to identify these crystals on the basis of infrared spectroscopy, and we were the first one who published their birefringent features. Once again, these very unusual crystals of uric acid are strongly birefringent and polychromatic under polarized light. On the left, you see images obtained by bright field and polarized light, while on the right part of the image, on the right upper part of the image, you see crystals of this category seen with phase contrast microscopy. Next slide, please. And we also may have very large aggregates of uric acid crystals, which have this appearance. Again, on the left side of the image, phase contrast. On the right side, we have strongly birefringent and polychromatic structures. Again, typical of uric acid crystals. Next slide, please. So we have seen the widest way that uric acid crystals are common, and they are the crystals which have, this is reality, the widest morphological spectrum, with morphologies which may be very, very difficult to identify only on the basis of morphology, birefringence features, and pH. Then we have amorphous phosphates. They are seen mostly in alkaline urine, the medium pH in our experience in which they are found is 7, in fact. These crystals are salts which appear as granules, amorphous granules in the urine, which cannot be distinguished by other salts which are amorphous urates, but they have the features that when they first appear in alkaline pH, and then if you polarize light, they don't have birefringence, quindi then they are not birefringent. And if the pellet you have after centrifugation is visible macroscopically, it has a typical whitish to beige color, okay? So amorphous phosphates are granular structure, amorphous structures, which do not polarize light, and which are found in alkaline pH. And after centrifugation, the macroscopic bottom, when visible, has this color. All this, next slide, is somewhat different, next slide, from what we found for amorphous urates, which are identical when seen by a bright field or phase contrast microscopy identical to amorphous phosphates. However, they first polarize light, as you can see on the left side and on the right side of the image. They are strongly birefringent under polarized light. Third, they appear in acid urine. The medium pH in which we have found them is 5.5. And after centrifugation, if the pellet is abundant, the color is very different from the color we have seen for phosphates. While with phosphate, we had a whitish or beige color. Here we have a reddish, pink to reddish color. Next slide, please. Now we have triple phosphate crystals, which have a typical, the most common morphology is that of coffin lid crystals, which under polarized light, for reasons which we don't know, or at least which I don't know, they may be either very strongly birefringent, as you can see on the upper part of the right side image, but the same crystals contained in the same sample can be negative. We don't know why. They are usually found in urine pH, in alkaline urine pH. Our median pH in our experience is in fact 7. So the coffin lid is the most common morphological shape. Next slide. We can have, however, other morphologies, such as those shown in this image. We may have prisms, which may be trapezoid or squared. And again, you see that the trapezoidal one on the right side of the image is strongly birefringent, while the others, for reasons which I don't know, are less or no birefringent. Next slide. We have, again, you see here, a very huge, big prism together with a small coffin lid triple phosphate crystal. And what is surprisingly, when we go under polarized light, is that the big prism is strongly birefringent, while the coffin lid is not birefringent. Next slide, please. And again, on the left side, we have another prism on the upper part with a coffin lid, and now we see what happens with polarized light, that the prism is not as birefringent as it was the previous one, while the coffin lid is strongly birefringent. So the birefringence of triple phosphate can be quite variable. And on the right side of the image, we have a very unusual shape, a very not so common morphology of triple phosphate crystals, which is a cross-like structure, which is, I would say, rather birefringent. Next slide, please. And we have calcium phosphate crystals, which are found in a urine pH from 6.6.5 with a median of 6. As you can see, they are quite often aggregated. They are, let's say, thin plates, which can be aggregated to form star-like structures. And they, as you can see, on the right side, they are strongly birefringent under polarized light. Next slide. Here we have another aggregate of calcium phosphate crystals, which have a club-like shape. Again, on the right, strongly birefringent. Next slide, please. And then we may have individual or aggregated, would say, needle-like structures. Again, on the right, strongly birefringent. This time, the polychromatic birefringence. Next slide. Again, we have more stick-like structures, always of calcium phosphate, always birefringent, strongly birefringent. Next slide. And now we have another variety of calcium phosphate. Calcium phosphate can appear as we have just seen, strongly birefringent crystals, stick-like, club-like, aggregated or not, while we can have calcium phosphate as plates, of which there are two types. Ones which plates with a granular surface, as you can see in both these images. Next slide. Or they also appear as plates, thin plates with a smooth surface. What is typical is that they appear in alkaline urine and they do not polarize light, so they are never birefringent under polarized light. Next slide, please. Okay, at this point, we have seen the whole category of common crystals, which is calcium oxalate, mono and bihydrate, uric acid, amorphous salts, which is amorphous phosphates and amorphous urates. We have seen triple phosphates. We have seen calcium phosphate for crystals and plates. What is the clinical importance and the clinical meaning of these common crystals? So calcium oxalate, uric acid, amorphous phosphate and urates, calcium phosphate crystals, in most instances are due to a transient supersaturation of the urine caused by, we say, physiological events, food, dehydration during the summertime, for instance, or changes of urine pH and or temperature upon standing. In such cases, they always indicate a transient supersaturation which is physiological, which may occur in everyday life. For instance, if you one day, it's a very hot day, you sweat a lot and you eat a lot of chocolate, for instance, you might have a supersaturation of urine due to calcium oxalate crystals, but this is not pathological. But especially when these crystals, common, are persistent in the same subject throughout different urine samples, they may be associated with metabolic disorders, such as hypercalciuria, hyperoxaluria, or hyperuricosuriaria. This especially in stone formers. So if I have we will speak about that in a few minutes. When we find instead the triple phosphate crystals, we must know that they are often, most of the time, times associated with urinary tract infections, which are caused by Proteus species and or urea splitting bacteria, such as ureaplasma or Corynebacterium urealyticum. So while calcium oxalate, uric acid, etc., may be not important, triple phosphate in most instances is associated with some types of infections. Next slide, please. And I have just mentioned stone formers. So it's important. So the evaluation of Crystalluria has a particular value, particular importance in stone formers, because the evaluation of Crystalluria may be a simple and inexpensive way to know something, to investigate the activity of the stone disease. And I show here to demonstrate that this, what I've just said, I mentioned the results of a paper published in Kidney International, which is an important journal for us nephrologists, in 2005 by the group of Professor Dodon. They investigated 181 patients with urinary stones due to calcium oxalate. They investigated 181 patients for a period of 6.8 plus minus 0.3 years, using the first urine of the morning. The crystals were examined by bright field plus polarized light. Do not forget polarized light at a low magnification, and some parameters were evaluated: their number, their size, the presence, absence, or aggregates, and their persistence over throughout the different sediments. What they found. Next slide, please. Next slide. It was found that in a patient with recurrent stone disease, which is with active disease, the presence of Crystalluria was significantly more frequent. So patients who had a tendency to produce stones over the time, they had Crystalluria more frequently than those patients who did not have recurrent stone disease, 68% versus 23%. And they found that the evaluation of Crystalluria over the time, it was found that they were more frequent in patients with the stone disease than those recurrent stone disease than patients with recurrent stone disease. So if you have, for instance, a patient who comes in your lab, we know that he is a stone former, the evaluation of the presence of the crystals and the recurrence, the persistence of the crystals throughout different samples over time is a very important marker of indicator of disease activity. Next slide, please. And the results I have just shown you led Professor Dodon to formulate this statement. Indeed, Crystalluria globally reflects the risk of stone formation as it integrates the complex interactions between promoters and inhibitors of lithogenesis, both known and unknown, either measurable or not. So the take-home message is that Crystalluria is a very simple and reliable method and inexpensive method to evaluate the stone disease activity in stone formers. Next slide, please. Other crystal features which are associated with active stone disease are number, volume, size, and tendency to aggregate. In our lab, we don't consider volume, we don't consider size, but no tendency to aggregate because we centrifuge urine. So the aggregation can be in part caused by centrifugation, but we consider always the amount of crystals and above all, their persistence over time in stone formers. Next slide, please. Okay, it's also important to know that common crystals, such as uric acid crystals, can be, as we have seen, that they can be a casual finding, not important from the clinical point of view. We have seen that crystals may be associated with metabolic disorders, such as those associated with stone disease. But in some rare cases, common crystals may also be associated with clinical acute kidney injury. And we will see in the second part of my talk one clinical case which demonstrates what I am just saying. Next slide, please. Okay, now pathological crystals. Before going through pathological crystals, I would like to know if you have questions about common crystals, which I have just described.
¿Me puede traducir la pregunta, por favor? Si los uratos amorfos y los fosfatos amorfos tienen alguna importancia clínica.
The clinical importance is the same as, for instance, if you have an hyperuricuria or you have a hyperphosphaturia, you may have, they may be a sign, may be an indicator, a marker of hyperphosphaturia and hyperuricuria. For these amorphous salts, it is the same as what I have just said for uric acid crystals, calcium oxalate crystals. They are particles which, if you can find them occasionally, okay, they may be not important. But if you see them persistently in the urine of the same subject, they may indicate hyperuricuria or hyperphosphaturia. Okay? Do you have other questions?
Preguntan en el público, ¿cuál sería el origen de los fosfatos amorfos y de los uratos amorfos? Si es por alimentos o algún medicamento.
No, they can be due, again, to food particles, so to some foods. For instance, uric acid, it is well known that it is associated with the high intake of meat or liver or a kidney food, okay? But that in the same time, they may be due to hyperuricuria caused by underlying diseases, as we will see in the first clinical case I will show you, okay? Other questions? I've seen a question which was written, which asked if centrifugation can cause aggregation. Is that true? Was a question which was actually raised to me?
Sí, por favor, please.
Okay, yes. There is no doubt that, for instance, in the laboratory of Professor Dodon, for the evaluation of Crystalluria in stone formers, native urine is investigated, which means urine which has not been centrifuged, okay? In our lab, we prefer centrifugate the urine because if you investigate native urine only, there is the possibility that if crystals are in small amounts, you don't see them. Because centrifugation is used to do what? Is used to concentrate the particles. Do you agree? So if you don't concentrate the particles, there is the risk that rare crystals are not seen. This is one thing. But on the other hand, we know that centrifugation is associated with some biases. And one bias is that since all the particles by centrifugation are, we can say, put at the bottom of the tube, they can aggregate. There is no doubt about that. It is true that once we remove the supernatant, then we resuspend the sediment with a pipette, etc. But we cannot exclude that some aggregates are due to the centrifugation per se. So it is not, in my opinion at least, if you use native urine, you don't have the risk of to create biases such as aggregates. On the other hand, if you have a small number of crystals and you do not centrifugate the urine, maybe you don't see them. That is the problem. Okay? So it's still an open subject which is open to discussion, debatable. Do we have other questions?
No por el momento.
Okay, can I go on? Okay.
Yes.
Pathological crystals. So these are the 5 types of pathological crystals. While las preguntas se hacen en el chat de preguntas, no habiliten los micrófonos. I don't understand. So these are the crystals. When they are present, they are always pathological.
Teacher, a moment, please. El público pregunta si puede activar su cámara, por favor.
En la mia cámara, let me see here. Let me see if I can move my stuff. No, my camera here, let me see. Integrated camera, okay. Okay, it's activated now. Can you see me? No. Video, let me. Let me, if I can integrate the camera. For some reason, it is not working. Abilita l'effetto specchio. Let me see. No, it doesn't work. I don't know why, but can you see me? No. I don't know why, but via video. Hang on. It's not working. I don't know why. It doesn't allow me to. Oh, I don't know why. Oh, If it doesn't work, I'm sorry. Can you hear me? Hello? Right. Okay, can you hear me?
Yes, doctor.
Okay, okay. So these are the crystals. When we find these crystals, they are always pathologic, okay? While uric acid, calcium oxalate may be non-pathologic, these are always pathologic. Cholesterol crystal, next slide, please. Next slide. Okay, cholesterol. They are thin, colorless structures of very variable size and shape, most often made of aggregated plates. Under polarized light, they do not have birefringence. What is the urine pH? Is their presence associated with a specific range of urinary pH? I don't have an answer. We are recording now the pH features of the samples with cholesterol crystals. But since they are not a common finding, we don't have yet sound data to tell you if they are or not associated with a specific pH range. What is the typical clinical association of these crystals? They are found in patients with severe glomerular proteinuria. In fact, they are a component of lipiduria, which is found in patients with nephrotic syndrome. So they are usually seen together with fat drops, oval fat bodies, and fat casts, okay? And next slide. This is their morphology, as you can see. They are thin plates which are made of aggregated, particles, one attached to the other or one upon the other. This is another example, two other examples of cholesterol crystals. When you find them, the clinical meaning is severe proteinuria. Next slide. Now we have cystine. Cystine are regular or irregular hexagonal uncolored thin plates of variable size, which may be isolated or heaped one upon another or appear in aggregates. Polarized light. The polarized light, the birefringence is either negative or positive, but when it is positive, it is from pale to shining white color. So the key word here is white color, negative or white color. Urine pH, they can be found in acid urine up to urine with a pH of 7.4. Above 7.4, cystine crystals dissolve. What is the clinical meaning? They have an important clinical meaning. When you find cystine, they are pathognomonic of the genetic disease cystinuria, which is a rare but not very rare disease, and is a very bad disease for the kidneys because it can lead to a chronic renal insufficiency up to a stage renal disease. In this disease, in cystinuria, the search of crystals is a simple, inexpensive, and reliable tool to diagnose the disease first and to evaluate its clinical course. Next slide, please. Cystinuria, as I told you, is a genetic disease associated with an autosomic recessive inheritance. There are 3 genetic subtypes, but all of them, each of them, cause renal stone disease with possible progressive chronic kidney disease up to dialysis. Next slide, please. And here you see the typical crystals of cystine. Urine pH, as I told you, from 5 to 7.4, and you see hexagon of different shape and size, quite often irregular, with birefringence which can be negative or positive, shining white. Next slide. Here, a large aggregate of irregular hexagons of cystine. And here on the left side, bright field, here we have polarized light. Some of the aggregated crystals are not birefringent, while a minority are birefringent, with again a whitish birefringence. Next slide, please. Again, another large aggregate of cystine crystals of different shapes and size. Some are fragments here, and you see again on the right side of the image birefringence, which can be negative, somewhat whitish, and birefringent, shining white birefringence. Next slide. Here, so far, we have seen cystine crystals under bright field and polarized light. Now, if we use phase contrast microscope to examine the urine sediment, cystine crystals, they don't appear as colorless particles, but as particles with some, you see, some colors. You see here, but again, they are very easily identified. Most crystals under phase contrast show these colors, but some of them are colorless, as we have seen with bright field microscopy. Next slide, please. What is important is that cystine appear as hexagons. And before, we have seen, while describing uric acid crystals, that uric acid crystal too may appear as hexagons. But what is a simple method to distinguish the two types of crystal is polarized light. With polarized light, uric acid crystals can be very easily distinguished from cystine crystals due to the fact that uric acid are strongly birefringent and polychromatic, while cystine is either non-birefringent or birefringent with white to shining whitish or shining white color. Okay, so this is very important. If you don't have the polarized light, it is difficult to distinguish these two types of crystals. At this point, can I ask you, how many of you who are attending this conference have polarized light equipment in their microscope for urine sediment examination? Can you? Fiorella Anguilleri, I know Fiorella. Hi, Fiorella. Fiorella is a friend of mine. He spent 1 month in our lab 3 years ago, I think. And I can tell you that she was a very, very, very good and motivated pupil. Fernando Velasquez, no, he doesn't have. Catalina, io tengo il Legara pronto, we don't have, okay? Someone else, please? Viviana, tutti gli esperti, no? Go ahead, please. No? No. Okay. So, okay. So, I noticed that many of you do not have. So, my recommendation is that you cannot do a urine microscopy of adequate quality if you don't have polarized light. Okay, so you must equip your microscope with polarized light, and the filters is the purchase of filters is not expensive. I remember that I bought the filters for polarized light for a microscope built in Italy for an African hospital, and I spent for the two filters 83 euro. So it's an expense which must be done if you don't have the polarized light in your microscope. Because if you don't have polarized light, you cannot identify crystals in a proper way, in a correct way. Okay, next slide now. Next slide, we can forget about this. Next slide. Okay, now we have 2A dehydroxyadeline crystals. These crystals are small round structures with a central depression, which is seen as a dark central spot. Under polarized light, they are birefringent, with an appearance which is that of Maltese crosses. pH, they are highly insoluble at any pH, so you can find them in very acid urine and in very alkaline urine. Clinical association, they are pathognomonic of congenital adenine phosphoribosyltransferase APRT deficiency in the blood. So if you find them, you make a diagnosis of a very severe kidney disease. The search of crystal or a potential very severe kidney disease. The search of crystals is a simple, inexpensive, and reliable tool to diagnose the disease and evaluate its course as it is for system crystals. I will show you a clinical case too, on the importance of the urine microscopy for the identification of this condition. I've seen that there are pupils which have questions probably, which raise their hands. What happens? Claudia Velasquez. Okay, can I go on? Next slide, please. Okay, so 2,8-dehydroxy crystals are due to the deficiency of adenine phosphoribosyltransferase deficiency. Aprt is an enzyme which transforms adenine, which derives from uric acid metabolism, in adenosine monophosphate. When Aprt is absent, next slide, please. Okay, next. Adenine cannot be transformed in adenosine monophosphate. At this point, next slide, adenine is transformed through the by the means of the xanthine dehydrogenase enzyme in 2,8-hydroxyadenine, which is highly insoluble at any pH. Okay, so dehydroxy crystals are pathognomonic of this condition, which is a genetic condition. Next slide, please. And these are the crystals, whatever pH, and these are roundish particles with a central depression, which under polarized light show a Maltese cross appearance. Here, these well-preserved crystals. This is a fragment of crystals, which show these different prisms, okay, with this polarized light, which is somewhat different from that of the crystals which are well preserved. Next slide, please. Here we have a typical 2,8-dehydroxyadenine in which the central depression is not so well seen, and which may show birefringence, which is not that of Maltese cross appearance. Why we can have these crystals rather than the previous ones, we don't know. We have seen these crystals in a patient we described some years ago in a kidney transplant recipient. Next slide, please. What is the role of urine sediment examination in patients with the genetic deficiency of Aprt enzyme? Here we have a statement of an expert in this disease, which is an expert from Iceland, which is a country in which this disease is endemic. And we see what the expert says about urine microscopy. Skillful urine microscopy is the single most important diagnostic procedure because urinary 2,8-dehydroxyadenine crystals are usually abundant in untreated patients. Okay, so again, we may diagnose a severe disease with a simple examination of urine sediment, as I will demonstrate you later, dealing when we will go to clinical cases. Next slide, please. Now we have leucine. Leucine, they are very rare crystals. They are yellow to brown round structures with concentric circles and or radial striations on their surface. Polarized light, birefringent, and with pseudo-maltese cross appearance. They are typically found in acid urine pH, and they can be found in advanced liver disease and in rare inherited metabolic disorders, such as overflow aminoacidurias. So if you have a production, an inherited metabolic disorder, which is characterized by the overproduction of leucine amino acids, you can find them also in the urine, because they are small proteins which can go through the the glomerular basement membrane filter. Next slide. Here we have a typical image of no, I'm sorry, this is not there is a mistake here. This is leucine, okay? So forget, this is not 2,8-dehydroxy. Leucine, you see concentric rings, okay? And a pseudo-maltese cross appearance. Strongly birefringent particle. Next slide, please. Now we have tyrosine. Again, tyrosine, as is leucine, is very rare crystal. They are colorless to yellow, fine needles, frequently aggregated in clusters or sheaves, strongly birefringent, found in urine pH. They, like similarly to leucine crystals, they are found in advanced liver disease and again in rare inherited metabolic disorder, such as those which can be associated with leucine in the urine. To note is that leucine and tyrosine crystals are often present in the same sample. If we have advanced liver disease, we may have the two types of crystals. Next slide, please. Here there are images of tyrosine. Unfortunately, we don't have in our image archive, which contains more than 9,000 images of tyrosine crystals. So I use these images, which are taken from the color atlas of the urinary sediment published by the College of American Pathologists. Okay? Okay, next slide, please. So I have finished now with pathological crystals, which always are associated with some pathological conditions. Do you have questions on these crystals?
Not it.
No questions? Can I go on? Okay, so other rare crystals. Very rare crystals. Next slide, please. This is a Uric Acid crystal. They are elongated and narrow hexagons. They are usually birefringent. Unfortunately, and I do apologize, we don't have an image showing the birefringence. They are found in acid urine, and in most instances, they are associated with diet in which there is an excess of certain vegetables. So they apparently, as far as we know, they are not clinically relevant. Next slide, please. Now we have calcium carbonate crystals. Here we have some images which we obtain from the urine of a horse. We will speak about calcium carbonate while dealing with clinical cases. In fact, the clinical case number 3 will describe a very interesting and unusual type of calcium carbonate crystal. Next slide, please. And now we have ammonium biurate crystals. They are roundish to avoid the structures with protrusions of different size and shapes. They are strongly birefringent, as you can see in the image, in the small inset of the image. They appear in alkaline urine. What is their meaning? And their meaning is rather uncertain, and I will tell you in a second why. Next slide. For instance, in the color atlas of the urinary sediment published by the College of American Pathologists, it is stated that ammonium biurate crystals are found in non-freshly voided urine containing ammonium produced by urea splitting bacteria. So it seems something associated with a delay in the examination of the urine sediment, a sort of artifact. While there are a couple of papers, both of them published by Japanese authors, which say that ammonium biurate crystals are associated with ammonium biurate stones, which can be seen in patients with severe dehydration associated with gastroenteritis caused by rotavirus. So on one side, it seems that the crystals are not relevant from the clinical point of view. However, there are a few papers, 2 papers as far as I know, which suggest that ammonium biurate crystals may be associated with dehydration caused by rotavirus, associated with gastroenteritis caused by rotavirus. So we need more information in the future to know what is the exact clinical meaning of these rare crystals. Next slide, please. Okay, now crystals due to drugs. Do you have questions about rare uncommon crystals of not certain of doubtful clinical meaning? Which is, I repeat, Uric acid, calcium carbonate, and ammonium biurate. No questions? Okay. Crystal due to drugs. Tyrosine, here we have a question which they ask, in which condition we can find tyrosine? I've seen that, I said that clearly. You can find them either if you have a liver disease, a severe liver disease, which is associated with the presence of tyrosine amino acid in the blood accumulation, and because probably it's not metabolized, and then it ends up in the urine, or you may have tyrosine if you have a genetic disease which is characterized by an increased production of tyrosine, which means high levels of tyrosine in the blood. Tyrosine amino acids are ultrafiltered at glomerular level, and because they are in high concentration in the blood, and there you find them in the urine. Okay. Another questions. Las dietas vegetarianas, they can. Okay, we will speak about that in clinical cases. Now, crystals due to drugs. We have 2 main categories of drugs which can cause crystalluria. Drugs which cause atypical crystals, which are made up of the drugs themselves. And here I will show you a clinical case later on. And drugs which cause calcium oxalate crystals. Okay, so next slide. Here we have drugs which cause crystals which are made up of the drug itself. We have sulfur diazine, amoxicillin, ciprofloxacin, which are all antibacterial drugs. We have acyclovir, which is an antiviral drug. Next slide, please. We may indinavir, which is a drug which was still used for HIV infection. Then we have felbamate and primidone, which are antiepileptic drugs. Then we have pyridoxylate. Next slide. Next slide, please. And hydroxyl oxalate, which is a vasodilator. We may have vitamin C in high dose. Oh, no, I'm sorry. Go back to the previous slide. Previous slide, please. Okay. All these drugs, so the ones which I've mentioned so far, they cause crystals which are made of the drug itself. All these crystals have very unusual morphology, okay, which we will see in images. And from the clinical point of view, also we will see what they can cause. Next slide. Now we have the second category of drugs which cause crystals in the urine, but they are not made of the drug itself. They are made of calcium oxalate. This is because these drugs cause an increase in calcium oxalate in the blood, and then which ends up, which causes an high concentration of calcium oxalate in the urine, supersaturation of the urine of calcium carbonate, and crystalluria. These drugs are the vasodilator naftidrofuryl oxalate, vitamin C when given in high dosage intravenously, and orlistat, which is a drug which is used to treat obesity. All these crystals cause calcium oxalate crystals, which for naftidrofuryl oxalate and vitamin C are monohydrate, while those caused by orlistat, we don't know from what is published so far whether they are mono or bihydrate. Next slide, please. And now, more recently, other drugs have been proposed as possible causes of crystalluria. However, of all these crystals, which are 1, 2, 3, 4, 5, 6, 7 drugs, you see that only for some of them, infrared spectroscopy has been performed. For instance, it has been performed for the atazanavir, which is an antiviral drug. It has been performed for darunavir, but it is not performed. It has not been performed for zonisamide, levofloxacin, methotrexate, sulfasalazine. So for these drugs, I think that is not yet sure that they can cause crystalluria. It is just a working hypothesis, but not as demonstration. While for sulfamethoxazole, which is a component of Bactrim, we will discuss a case, the fourth clinical case of this conference. Infrared spectroscopy has been performed. So what is important is that to be sure that the drug crystal is due to drug, in case you are dealing with drugs which are not those which cause calcium oxalate, it is important always to be sure that the crystals are made of the drugs, and this can be obtained only with infrared spectroscopy. And to be honest, I don't know how some papers have been accepted while without infrared spectroscopy. Next slide, please. So some examples. We have an example of sulfur diazine. You see very clearly that the morphology of this crystal is suspicious for a drug because it has nothing to do with the morphology of crystals which we have seen so far. No uric acid, no calcium oxalate, no triple phosphate, no calcium phosphate, etc. Next one. Next. Another example of sulfur diazine crystals, which we have seen quite recently, or last year, I think, in our lab, and which we have seen, first of all, with an automated instrument, which is able to obtain images in bright field and phase contrast. You see this typical morphology of sheaves, okay, or okay, typical of sulfur diazine. And you see here that under manual microscopy, polarized light, they are always strongly birefringent. This is important. Next slide. We have acyclovir. They appear as needle-like structures. This is an image which has been taken from the New England Journal of Medicine. We have not yet seen acyclovir crystals in our lab. And since several crystals may have disappearance. Infrared spectroscopy is important for their sure identification. Next slide. Now we have amoxicillin. You see again unusual features with very interesting birefringence, interesting birefringence under polarized light. It was a case of amoxicillin crystalluria, which we could identify again with certainty again by the means of infrared spectroscopy performed in Paris for us. Next slide. Here there are different examples of indinavir crystalluria. These are crystals of different size and shape, which are always strongly birefringent. Birefringence is seen in the lower part of the images. And this is drug which is used especially in patients with HIV infection. Next slide. Now we have ciprofloxacin. These are different images of ciprofloxacin crystals, which we were able to identify again with certainty after infrared spectroscopy. Next slide, please. Another example of ciprofloxacin crystals, which were shown in the cover of this issue of the American Journal of Kidney Disease, in which our group supplied these images in a core curriculum article on urine microscopy. Next slide, please. Which are the factors which favor drug crystalluria? Drug overdose, of course, dehydration, hypoalbuminemia, because dehydration means it's a sort of drug overdose. Hypoalbuminemia, because with hypoalbuminemia, the free fraction of the drug is increased, and the presence of reduced GFR due to, which is reduced glomerular filtration rate, presence of pre-existent renal insufficiency due to pre-existing nephropathy or to interferon drugs. And of course, as usual, the urine pH. Next slide, please. See that the pH again is important also for the precipitation of crystals due to drugs. Sulfur Diazine is found in acid urine. Amoxicillin can be seen both in very acid or in very alkaline urine. Ciprofloxacin if the pH is more than 7.3. Indinavir if the pH is more than 6. And sulfamethoxazole, which we will see in clinical case number 4, in a pH which ranges from 5 to 6.5. Next slide, please. Which are the clinical manifestations of drug crystalluria? We may have isolated and asymptomatic crystalluria, as we will see in our clinical case. We may have hematuria, either microscopic or gross hematuria, with without leukocyturia, which is caused by the damage which crystal cause on the epithelium of the excretory urinary system. We may have rarely an obstructive uropathy due to drugs stone when the concentration of the drug is very, very, very high. Or we may have acute kidney injury due to intratubular precipitation of crystals. We will see in one of our clinical cases in the next minutes. Next slide, please. Which are the general rules to remember about crystalluria due to drugs? These are very important. Think of a drug whenever you come across crystals with unusual morphology, without forgetting, however, that drugs such as naftidrophoril oxalate, vitamin C, and orlistat cause crystals with common morphology, which are calcium oxalate crystals. So if you come across crystals which have unusual morphology, you must always think of a possibility of crystals due to drugs. And the first thing to do is to investigate whether the patient is taking or not drugs. If the patient is not taking any drug, it is not a drug crystal, of course. Once we know that the patient is taking a drug and we have a suspicion which is a crystal due to drug, we must check the renal function, because some drugs in some conditions can cause crystals associated with acute kidney injury. And from the clinical point of view, one thing which has been done is, if it is possible, to stop the drug, or to reduce the dosage of the drug, or to hydrate the patient in order to prevent the further precipitation of crystals. Or also is to change the urine pH with alkalizing or acidifying substances. Next slide, please. Wow, I have finished. So we have finished my presentation on crystals and their classification, morphologies, and clinical meanings. And now we will go through 4 clinical cases. But do you have questions on this last part of my presentation? Please, if you have, go ahead. Do you have questions?
Al público si hay algún conservante para la lectura de los cristales.
No, conservantes no es bueno, porque los conservantes can cause changes of pH, and with the change of pH, this is an interfering factor for the evaluation of crystalluria. So, for instance, in stone formers, if you want to evaluate the crystalluria in a proper way, what we have to do, and this is what we do in our lab, when we have a stone former which is sent to us for the evaluation of crystalluria, the urines must be as fresh as possible. So we tell the patient, please come in our lab. You will produce your urine in the toilet next, close to our lab, and we will go through, examine your sediment in the next 20 minutes. No preservatives, because they may change pH, which is a very confounding factor for the evaluation of crystallurias.
¿Es posible observar cristales de omeprazol en orina?
Omeprazole, as far as I know, I don't know. I don't know. Have you found omeprazole in let's say, in PubMed? Maybe, I don't know. But my last review in PubMed didn't speak about omeprazole. Have you ever experience of? Have you heard about omeprazole and omeprazole crystals? This is my question to you. Have you ever personal experience of omeprazole crystals, or have you found in the literature something dealing with omeprazole crystals?
No.
Okay. Okay. Other questions? Okay. Any more questions? Please, I've seen that there was some differences concretas entre ácido úrico hipúrico e ácido úrico hexagonal. It's a good question, because both of them can be found in acid urine. The problem is that all the investigators have, I can tell you that because I'm in direct contact, for instance, with Professor Nancy Brunsell, who published a very important book. Uric acid are very, 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 very rare crystals, so it is difficult to distinguish them from uric acid. What I can say is that, as far as we know, based on the very small experience we have, is that uric acid are elongated and narrow hexagons, while uric acid are more irregular hexagons. but I don't personally have a clear-cut answer to your question. But is that the problem is that uric acid is very, very rare, so it is difficult also to have reliable information about those crystals. I'm sorry about that. Do you have other questions? Any more questions?
No, teacher.
Okay. Can we go on? Can I go on?
Continue, please.
Okay. So these are the 4 clinical cases. First slide, please. Next slide. Okay. A woman with severe crystalluria and acute kidney injury. I told you before that common crystals can be associated with, in some cases, with acute kidney injury. Next slide, please. On February 7th, 2009, an 82-year-old woman is admitted to the emergency unit of our hospital for malaise, vomitus, started 1 month before, associated with progressive reduction of food and fluid intake and reduced urine output. A physical examination, blood pressure is low without treatment. The skin hypoelastic, mucosa are dry, and the patient suffers from intense thirst. So, next slide, the first clinical hypothesis, working clinical hypothesis, next slide, is that the patient is a dehydrated patient. Serum creatinine is very high, 8.8 milligram per deciliter. There is a severe metabolic acidosis. And by ultrasound, the kidneys are mildly hyperechogenic without obstruction. So, as I told you a few seconds ago, I think it's an acute kidney injury due to dehydration. The cause which is behind malaise and vomitus is, however, unclear. So we start the hydration of the patient, and the patient is hospitalized in internal medicine unit, not in nephrology, because at that time we didn't have a bed which could be used for this patient. Next slide. 2 days after hydration, serum creatinine improves a bit from 8.8 to 7.7, but still severe acute kidney injury persists. In addition, we found a very severe hyperuricemia, 28, with a normal value, which is up to 5.7, increased LDH, very increased, and we have a reduced number of white blood cells, red blood cells, and platelet cells. So there is a condition which is characterized by very severe acute kidney injury, very severe hyperuricemia. These are the most important 2 lab features. Next slide. And when we analyze the urine, by dipstick we find the pH is acid, specific gravity is 115, albumin in 1+, hemoglobin 3+, leukocyte esterase 2+, with nitrites which are negative. Urine sediment show a few red blood cells, a few white blood cells, some renal tubular epithelial cells, bacteria 4+, and in fact there is an infection caused by Escherichia coli and Enterococcus species. But next slide, especially, we find in the urine, next slide, a 4+ uric acid crystals, 4+ uric acid crystals. Next slides. And these are the uric acid crystals. This is an image on the left side obtained with phase contrast, low magnification. There is a very large aggregate of uric acid crystals, which are identified due to their morphology, their pH, and their B-refringent features. Strongly B-refringent, and polychromatic. Next slide. Here, see another image of that urine. Again, a large aggregate of uric acid crystals, all of them polychromatic birefringent with polychromatic birefringence. Next slide. At this point, we have a severe acute kidney injury associated with marked hyperuricemia, increased LDH, reduced blood cell counts, marked uric acid crystalluria, urinary tract infection. So the most important things are severe acute kidney injury, marked hyperuricemia, and marked uric acid crystalluria. At this point, since we know the uric acid crystalluria is associated with acid urine, we alkalinize the urine and we give the patient allopurinol to reduce hyperuricemia. Next slide, please. In fact, with alkalinization of urine and allopurinol, the situation improves a bit. Serum creatinine decreases from 7.7 to 4.2. Uric acid also improves from 28 to 16, 15.7, but still remains very, very high. And in the urine, if we go in the urine sediment, what we see? Let's go on with the next slide. Again, a high amount of crystals, which are again strongly birefringent under polarized light, even though their morphology compared to the previous one, to the crystals we have seen 1 minute ago, they are somewhat different, and we don't know why. Next slide. And here you see a very large aggregate amounts of those crystals. So there is a partial improvement of acute kidney injury, a partial improvement of hyperuricemia, but crystalluria is still massive. At this point, next slide, we change our treatment for hyperuricemia. We give the patient rasburicase intravenously, which causes an improvement of uricuria from uricemia from 15.7 to 0.6 to 5 milligrams DL. With this a modification of correction of hyperuricemia, we see that also crystalluria disappear rapidly and completely, and in few days serum creatinine decreases to normal value. Next slide. At this point, due to the fact that we have a reduced white blood cells, red blood cells, and platelet count, we submitted the patient to a bone marrow biopsy, and we found that the patient was suffering from acute lymphatic leukemia. And at this point, we came to the conclusion that the patient was suffering from acute kidney injury associated with very severe hyperuricemia, very severe uric acid crystalluria, both secondary to acute lymphoblastic leukemia, a condition which is known as tumor lysis syndrome. What is important from our point of view as people dealing with urine microscopy is that the regression we found a complete regression of crystalluria and of acute kidney injury when we corrected the hyperuricemia with the rasburicase, which is a drug which degrades uric acid in allantoin, which is purine in allantoin, which is 10 times more soluble than uric acid and is easily eliminated by the kidney. Next slide, please. In tumor lysis syndrome, acute kidney injury is mainly the consequence of the precipitation of uric acid crystals in the renal collecting ducts. We have not performed a renal biopsy in this patient in order to demonstrate this, because we obtain a very clear-cut improvement of hyperuricemia, acute kidney injury, and crystalluria with an appropriate, adequate treatment of the situation. What is important is that the examination of the urine sediment is a very valuable, quick, and inexpensive tool to diagnose the renal involvement in tumor Lysis syndrome and the follow-up of its course. So the precipitation of urinary crystals you will see in the next in one of the next clinical cases. So first case demonstrates that uric acid crystals can be associated with acute kidney injury when they precipitate in the renal tumors, as it may happen in patients with tumor Lysis syndrome. Do we have questions about this case? No questions?
No, teacher.
Okay. Case number 2. Next slide, please. A boy with crystalluria and renal stones. Next slide. On 8 February 2017, many unusual and birefringent crystals are found in the urine sediment of an 11-year-old boy. The urine pH is 5.5. We see these images, which on the left side of the slide are round particles with a central dark spot, and which under polarized light on the right side of the image show a Maltese cross appearance. What is your hypothesis? Which crystal this might be? There is someone who can answer me? No answers? Okay. Can I go on? Okay, Fiorella, okay, that's interesting. So we have some of you who say 2,8-dehydroxyadeline and one who said leucine. Next slide, please. Okay, we had, based on the morphology alone, we didn't know anything about the patient. We said might be leucine or 2,8-dehydroxyadeline. This was our working hypothesis. And also we thought both of them are rare, but 2,8-dehydroxyadeline is more rare than leucine. So our first hypothesis was maybe it is leucine. Next slide. The day after, through hospital intranet, it is found that liver enzymes are normal. So, which weakens leucine hypothesis. You remember that leucine and tyrosine can be found in two conditions: advanced liver disease or in genetic diseases associated with high levels of tyrosine and leucine in the blood. So liver enzymes are normal. But also we found that the boy is under observation and treatment in the pediatric emergency unit for a colicky pain associated with left kidney stones. Thus, at this point, we have a severe and unusual crystalluria associated with kidney stones in an 11-year-old boy. At this point, we if we put all these clinical findings together, the working hypothesis we had immediately in mind is hereditary disease due to a congenital deficiency of adenine phosphorybosyltransferase transferase, Aprt. Okay, so our working hypothesis was that these are crystals of 2,8-dehydroxyadeline, because finding stones in an 11-year-old boy is strongly suggestive for a genetic disease. Next slide. After the reversion of the colic, the boy is discharged and is enrolled in the urinalysis clinic of the pediatric nephrology unit of our hospital, where a new check is planned in 2-week time. And in fact, after 2 weeks, a new urine sample is supplied to our lab. And the urine sediment examination confirms the presence of a severe crystalluria which is identical with the previous one. In addition, an aliquot of urine is filtered, dried, and shipped to Professor Dodon in Paris for infrared spectroscopy investigation. Next slide. And these are the urine sediment, which we found on the 27th of February. Aggregates of crystals similar to the previous ones, which typical bright field appearance and typical polarized light birefringence. You see here on the bottom part of the slide a fragmented broken crystal, large broken crystals, which have a different birefringence compared to the well-preserved crystals, which we can see in the upper part. Next slide. And these, again, we may have other aggregates, which crystals the birefringence of which is not always characterized by Maltese cross appearance. And if you remember, I have already mentioned these crystals, which are a bit unusual and with a different polarized light birefringence from the classical ones, and we don't know why. I also discussed about this situation with Professor Dodon, and he too did not have an answer to these questions, why some crystals have a classical appearance with classical Maltese cross under polarized light, and others like this do not have this classical appearance. And next slide. The crystals in this second sediment also appear in aggregates, some of which have a very nice appearance. This is a nice denser. You see here, it is not a Photoshop, it is an image as we found in our investigation of the urine sediment. And here you will see on the right side, again, Maltese crosses appearance is very nice. We measured these crystals. Giuseppe Garigali, our biologist who is in charge of the examination of the urine sediment in our lab, measured 50 crystals and found that they have a median diameter of 6 micrometers. So they are small crystals compared to other crystals. Next slide. This was on the 27th of February. Next slide. On the 28th, we measured the RP, the adenine phosphoridyl transferase in the peripheral red blood cell lysate of the patient. It was done by Professor Ritz, who is a professor of the University of Pavia, and it was found that the Aprt was very low, 1 milligram, 1.1 milligram, with a normal value between 6.5 and 44.6. So we had typical 2,8-dehydroxyadeline crystalluria associated with decreased level deficiency of Aprt. Again, we can go on. Next slide, please. On the 23rd of March, we have the results of infrared spectroscopy by Professor Michel Dodon of the crystals, who found a typical spectrum of 2,8-hydroxyadeline. Next slide. And finally, the patient was submitted to a surgical removal of stones from the left kidney. During surgery, a kidney biopsy is performed, and only very few 2,8-dehydroxyadeline crystals within the distal tubules are found. So there are no signs of crystalline nephropathy in this case. Next slide. The day after, infrared investigation of the removed stone performed in our lab, in our hospital, confirms that the stone is made of 2,8-dehydroxyadeline. So our final diagnosis is left kidney stones and crystalluria due to inherited Aprt deficiency in an 11-year-old boy. Treatment with allopurinol is started, 100 milligram per day. And with this dosage, there is the crystalluria is persisting. But once the dosage of the drug is gradually increased from 100 to 200 and then to 300 milligrams per day, the crystalluria disappears. Next slide. Summary: an accurate and complete diagnostic and therapeutic roadmap, opened and closed in 50 days for a rare and severe kidney disease, which was started and triggered by motivated and skillful urine sediment examination. So we prevented a very severe and chronic severe kidney disease in this young boy, thanks to the fact that we examined in a proper, motivated way the urinary sediment of this patient. Next slide. What is Aprt deficiency? We have already seen. Next slide. So we have already seen. Please go ahead. Go ahead. Go ahead. Go ahead. No, ahead. Ahead. Go ahead. 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 We've already seen this. No, go ahead. Okay. There are two types of Aprt deficiency. Type 1, which is enzyme activity very, very reduced, virtually absent. And this type 1 is found especially in Caucasians. And type 2, which is found especially in Japanese population, in whom the enzyme activity is not as low as it is in type 1. Anyway, the clinical manifestations are the same. Next slide, in the two conditions, type 1 and type 2. Next slide. And what clinical events have we prevented to our young patients by making the diagnosis of the dehydroxyadeline deficiency based on urine sediment examination? Next slide. The deficiency of the enzyme can cause recurrent stones, kidney stones, 65% of cases, can cause acute kidney injury from intrarenal precipitation of 2,8-dehydroxyadeline, which is seen in about 25% of patients. It can also cause chronic kidney disease from possible chronic interstitial nephritis, is in about 1/5 of patients. Next slide. I show now some images of intrarenal precipitation of 2,8-dehydroxyadeline associated with severe acute kidney injury in a kidney transplant recipient with a Aprt deficiency. Next slide. Okay, here we have, this is a renal biopsy. These are tubules, kidney tubules, and you can see here that the lumen of tubules is obstructed by these crystals, okay, which are present both within the tubules and within the interstitium of the kidney. So this is what happens when there is the precipitation of 2,8-dehydroxyadeline, and this may cause acute kidney injury. And this mechanism is similar to what I have described for uric acid precipitation in the patient with lymphoblastic anemia, clinical case number 1. Next slide. You see again, here we have renal tubules, and this tubule is completely occupied, obstructed by birefringent crystals. And here we have other crystals, and here even we have a cast, an intratubular cast, which contain crystals, which can be seen very well here. Hematoxylin, eosine, and polarized light. Okay, next slide. Other images. You see here again, these tubules are completely or almost completely obstructed by the crystals which precipitated in the renal tubules and then elicit a an inflammatory reaction in the intestine, which is another cause for acute kidney injury in these patients. Next slide. Next. So we published these patient, these clinical cases in Clinica Chimica Acta in 2019 with this title, A Virtuous Diagnostic and Therapeutic Roadmap Triggered by Motivated and Skillful Urinary Sediment Examination. I think that is very important to be able to prevent a very severe disease, chronic and acute kidney disease. Thank you to the well done urine sediment examination. Here there is a mistake, so I'm sorry. Roadmap D is NSS. Next slide, please. We may have so crystalline acute kidney injury. So it was a case of acute kidney injury due to the precipitation of crystals within the tubules and interstitium. This condition is part of the so-called crystalline acute kidney injuries. We have seen two cases of crystalline acute kidney injuries in these clinical cases. The first one due to tumor lysis syndrome, also known as acute urate nephropathy. Another situation which can cause crystalline acute kidney injury in the precipitation of ethylene glycol, which is a substance which is used in antifreezing fluids. We may have drugs such as amoxicillin, ciprofloxacin, indinavir, etc. We have already mentioned them. We may have metabolic disorder such as 2A dehydroxyadeline, and we may have acute kidney injury associated with crystals, also myeloma kidney, because of the precipitation of crystalline light chains. And finally, we have crystalline, we may have crystalline acute kidney injury due to foods for star fruit or Averroia caramba, which is typical of Southeast Asia. What is important is to realize that in some instances, both common crystals or special crystals due to drugs or to metabolic disorders or to myeloma kidney can cause acute kidney injury. In these cases, acute kidney injury is mainly due to the intratubular precipitation of those crystals. Next slide. Oh, do you have questions about crystalline nephropathies or 2A dehydroxyadeline? If you have questions, I will be happy to try to answer you.
Profesor, hay una pregunta de ácido hipúrico.
You also no. You already asked about uric acid, okay? Uric acid is a very rare crystal, and there is almost nothing in the literature, so it is very difficult. So the clinical association of uric acid crystal is maybe it is associated to the diet containing vegetables, but it is a field which has to be explored. We know very few things about uric acid crystals. Why are you so interested in uric acid crystals?
Preguntan si el ácido hipúrico ha sido confirmado con espectrofotometría infrarroja o tal vez es otro cristal con el que se está confundiendo.
No, to be sure, we should perform infrared spectroscopy. The problem is that it is so rare that our approach would be, if one day we can suppose tomorrow we come across a crystal, some crystals which may suggest uric acid, the first thing we would do is to filter the urine and perform infrared spectroscopy. But the problem is that crystals with an appearance suggesting uric acid are very, 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 very rare. in my personal experience, and I've been working on urine sediment for 40 years now, I think I've seen a uric acid 1 or 2 times. That's it. So how can I go on with investigation? And if you look also in other test books, you find almost nothing about the uric acid crystals. They are very rare. But the general opinion is that they are not clinically relevant, while other crystals are more important. Okay?
Thank you.
Other questions? Do we have other questions?
No, teacher.
Okay, can I go on? Okay. On March 25, 2003, very unusual crystals are found in the urine of a 30-year-old woman who is in the 8th week of her pregnancy, first pregnancy. The patient is under medication with folic acid, iron sulfate, and levothyroxine. So unusual crystals in a patient who is pregnant and under medication with some drugs. The first thing we did was to go through PubMed to see whether there were crystals, if these drugs, folic acid, iron sulfate, and levothyroxine, could cause unusual crystals, similar unusual crystals, or crystals at all. Those drugs did not cause, as far as we could see in PubMed, crystalluria. Next slide. The thing we also knew was that the day before urinalysis, the patient had eaten large amounts of vegetable, especially spinach and salad. Next slide. The pH was alkaline, 7.5. Specific gravity was 125, so concentrated urine. And all the parameters of dipstick, albumin, hemoglobin, etc., were all negative. Next slide. So we had only alkaline urine and an unusual crystalluria in a pregnant woman. Next slide. A 2+ crystalluria without any other particle is found. The crystals have a very unusual morphology, never seen before, which we define as daisy-like crystals. Please show the image. Next slide. Here are these crystals. On the left, bright field. On the right, phase contrast images. So you see they are daisy-like, flower-like crystals, never seen before in our own experience, and not seen, as far as I could remember, in textbook atlases I was using in my everyday practice. Next slide. At this point, in order to know what crystals they were, we undertook two steps. One was review of the images of crystals contained in books of our specialized library. We have a specialized library on urine and urinary sediments. And two, we filter the urine and send the urine to Professor Dodon in Paris to perform infrared spectroscopy. Next slide. This is the historical library, which I have at home and which is close to me now. It is on my left in this moment. These are the historical books on urine, sediment, urinalysis, urine microscopy. And then we have the second part of our specialized library in our lab, which contains the more recent books. Anyway, in that occasion, we went through 58 books devoted to urinalysis, urine sediment, or clinical microscopy. 43 books were historical ones, which covered the period from 1844 to 1974, while 15 books covered the period 1981-1999. Don't forget that we were in 2004, 2003. Altogether, we examined more than 1,530 images of crystals. 1,530. And next slide. We found similar to ours in only 2 works, which were, next slide, old works. Next. We found images similar to our crystals in a book published in France in 1853, in which these crystals were identified as calcium carbonate crystals, which had been found not in the urine, but in the saliva of a dog. The images are quite similar, identical to our crystals. Next slide. The second book in which we found these crystals was a book published in Austria in 1871, in which those crystals were identified as creatine and zinc chloride as possible contaminants of the urine. Next slide. So at this point, after the review of our specialized, the books of our specialized library, we had one possibility calcium carbonate, the other possibility creatine and zinc chloride as contaminant, let's say, of the urine, and our patient. Unknown daisy-like urine crystals. Next slide. At this point, we had the answer from Professor Dodon. Based on infrared spectroscopy, we could say that crystals contain calcium carbonate. However, the infrared spectrum did not correspond to calcium carbonate commonly found in biological fluids. Therefore, our crystals, we learned, were made up of calcium carbonate, but a typical one. That was, we could know in that occasion. Next slide. At this point, we became very curious about calcium carbonate crystals. So we went through the recent literature about calcium carbonate crystals. And we found that they are rare in humans. They are a frequent finding in the urine of horses and other herbivores. They may have a pleomorphic morphology from dumbbells to four-leaved clovers, daisies, pumpkins, etc. And they are birefringent under polarized light, while our crystals were not birefringent under polarized light, not at all. They are found in alkali urine, as our crystals were, and they are associated with effervescence of the urine by adding acetic acid to the production of carbon dioxide. We didn't use acetic acid in our patient, in our sample. The clinical significance in humans is very uncertain. Just due to the ingestion of large quantity of vegetables, this is what we found in the literature at that time. Next slide. At this point, we tried to have some more images of calcium carbonate crystals. And to do that, we obtained from a resident who was in that period working in our hospital, the large samples of a horse urine. Next slide. We found crystals with the shape of dumbbells. One of these crystals was similar to our crystal, daisy-like crystal, but under polarized light. Next slide. Next, this is phase contrast. Next slide. Under polarized light, all these crystals will be birefringent, while our crystal was not birefringent. In addition to that, in order to be sure that this was calcium carbonate, we filtered the urine and sent the filtered urine again to Paris without saying that it was the urine of a horse. We said it was the urine of a patient about whom we didn't know anything. And the answer came back this is typical calcium carbonate urine. So we learn from our patient that these crystals, similar crystals, could be found in the urine of a horse. However, while the crystal found in the urine of a horse were birefringent, our crystals were not birefringent. Next slide. In addition, we asked a young doctor working in our urine group to eat quite a lot of spinach in one day. She ate almost 1 kilogram of spinach in one day. The day after, we analyzed the urine, but no crystals we could find in the urine. So we couldn't obtain any information about the possible link between spinach and the crystals we have seen in our pregnant patient. Next slide, please. We published this case in 2004 in Nephrology Renal Transplantation with this title, An Unusual Type of Crystalluria, appearing only once every 130 years. This was our question. Let's go now and see what happened subsequently. Let's go on. Next slide. However, in the following years, we were contacted by email by 7 different colleagues from 5 different countries who also had found Daisy-like crystals in the urine sediment of different patients. So that in 2017, which is 13 years after the first report, next slide, we were able to publish this paper in Clinica Chimica Acta, the title of which was Daisy-like crystals, a rare and unknown type of urinary crystals. In this paper, we described 9 patients whose urine sediment contained Daisy-like crystals identical to the ones we found the first time. And some of these patients were pregnant, others did not. So we found that there was not a special clinical condition which was associated with those crystals. The age of the patients ranged from 3 to 93-year-old. All the patients were female but one, who was a 19-year-old male. The urine pH of the varied ranged from 6 to 7.5, so alkaline urine. The crystals were identified almost always, I would say, only in one case were seen by manual microscopy, and in all other cases by automated analyzers of urine sediment. And the associated particles was, in some occasions there was nothing associated, in other cases there was other crystal, such as calcium phosphate, in 2 occasions, needle-like calcium phosphate crystals. This is because the urine was alkaline, at an alkaline pH. In addition to these 9 patients, it was found that the urine contained Daisy-like crystals also in a dog, which was seen by a veterinary doctor working in Brno in Czech Republic. So our paper contained 9 described the Daisy-like crystals seen in 9 human beings, plus the Daisy-like crystals seen in the urine of a dog. So these crystals are rare, but not so rare as we hypothesized in the first papers. They appear more frequently than once every 130 years. Next slide. Here I show you the images of some of these crystals as seen by automated instruments. This is an automated instrument IQ 200. They are identical to the one we have seen, we described in the first paper. This was seen in a pregnant woman from Zagreb, Croatia. Patient number 2. No, number 2. Next slide. These are manual microscopy. Daisy-like crystals seen in the urine of a 3-year-old girl, and here associated with calcium phosphate aggregates with star-like appearance. Next slide. These are daisy-like crystals seen with another automated instrument, which is Sedimax, and which is seen in bright field. Next slide. At this point, after one patient described in 2003, 4 other 9 human beings described in 2017, together with the urine of a dog, this story goes on. And in fact, in 2021, this year, we were able, I was one of the authors, but the paper comes from the crystal lab of Professor Dodon. We describe the urine of the crystals found in the urine of a 64-year-old woman. 3 types of crystals were present in that urine. Type 1 lozenges, type 2 daisy-like, and type 3 needle-like. Well, these crystals were all investigated. Next slide, please. I know, excuse me, can you go there? Can you go back? No, if you back. Okay, these crystals were investigated by infrared spectroscopy and other sophisticated infrared techniques, which you can find. Please go back. Go back. Okay, and it was found that crystal number 1 were, all these crystals were variant of calcium carbonate. Type 1 was calcite. Type 2, our daisy-like crystals, were made by vaterite, while type 3 were made to another type of calcium carbonate, which I cannot read here. Can you read there? Calcite, vaterite, and can you read them? No. Anyway, what is important is that in 2021, we were able to identify the nature of daisy-like crystals, which means they were a variant of calcium carbonate called vaterite. Please go back to the previous slide. You're going too fast. Can you go back, please? Can you go back, please? Back. You are going, no, backwards. Okay. After publishing the paper in which it was demonstrated, oh my God, stop there, please. After demonstrating that those crystals are made of vaterite, next slide. Next slide. A paper, next. You are going back, next. Please, next. Okay. A paper was published in Clinical Chemical. No, please, stop there. Go back and, no. Excuse me, can you go back? Back. One more back. Stop there, please stop there. A patient has been published in which extremely rare daisy-like crystals in urinary sediment were due to a sampling artifact. In fact, daisy-like crystals were found in the urine of a 5-year-old girl whose urine had been collected in a glass recipient, which had been sterilized by the patient's family. The night before, sample collection by boiling water with high calcium and magnesium content and letting the recipient cool overnight. So the hypothesis, the final hypothesis of the paper was that sampling artifacts are therefore a possible explanation for at least some of the previously described daisy-like urinary crystals. Next slide. In order to verify this hypothesis, next slide, I contacted all the colleagues who had supplied the patients with daisy-like crystals in the urine we had described from 2003 to 2021. And we found that the results shown in the letter published in the same issue of Clinica Chimica Acta in which the previous paper was published, demonstrate that out of the 11 subjects had used appropriate sterile plastic containers, while for 2 other subjects, no information could be retrieved. In addition, one of the authors found that daisy-like crystals can also be found in the seminal fluids of 2 male patients investigated for infertility. And also in this patient, the sperm had been collected in a plastic sterile jar. So, next slide, at this point, next and last slide. At this point, we expect some new interesting information in the future. Which one will it be? So, all this case demonstrates that with simple urine sediment examination, not only it is possible to diagnose severe diseases and to help our patients, it is also possible to perform scientific map roads and find interesting discoveries which are very interesting. So urine sediment is not only useful for our patients, is also useful for clinical research and at a very low cost, always at a very low cost, okay? So at this point, I would have one more case, but I think that I have been speaking for 3 hours now, 2 hours and a half. If you think that it is enough, I can stop it. If you want to, I can go on and show you the last case. Please tell me what you prefer.
Continue, please, teacher.
You want me to continue? Okay, last case. Next slide, please. A kidney transplant recipient with 2 types of crystals in his urine. Oh, this paper is on the importance of polarized light in urine sediment examination. Next slide, please. On July 15, 2014, a 50-year-old man of Moroccan origin is submitted to periodical control in the outpatient clinic. 2 months before, this is important, the patient had been submitted to kidney transplant from cadaveric donor for uremia due to P-ANCA positive plus systemic vasculitis. On July 15, serum creatinine is 1.7, uric acid normal, urine dipstick, urine pH 5, specific gravity 130, with hemoglobin, leukocyte esterase, and albumin negative. Next slide. Urinary sediment findings: hyaline and hyaline granular casts, monohydrate calcium oxalate crystals, 1 to 3 per hyper field, and in addition, hexagonal crystals, 1, 3 per high power field. So far, we have mentioned hexagonal crystals for 3 types of crystals: uric acid crystal, cystine crystals, and Euphoric acid crystals. And we said that for uric acid crystals, they appear in acid urine with birefringence, polychromatic birefringence at polarized light. For cystine, we said they can be found in a urine from acid to alkaline urine up to a pH of 7.4 with birefringence which can be negative or positive whitish to shining white. And then we spoke about Uric acid, very rare, which are found in acid urine and are birefringent, but without any image. I do not have image myself, and I haven't found images in the literature. So which hexagonal crystals were there? Were there uric acid, uric acid, or were they cysteine? Next slide, please. So these are the crystals we saw. Can you click? Go ahead. Click on the slide. Next slide, please. We found three types of crystals. One were monohydrate calcium oxalate. Then we have hexagonal crystals heaped upon another, complex and large. We call them type 1. And then please click hexagonal crystals as individual thin plates, simple and small, 14 micrometer versus 27. And these are these with the greenish circle. You see here, so red circle, complex type 1. This is crystals, complex crystals larger than the so-called type 2. Okay. At this point, it is important to perform polarized light, to apply polarized light. Next slide, please. Next slide. And polarized light show that the urine contains crystals which are partly strongly birefringent. And next slide, please. Again, next slide. Click. Okay. Those which are strongly birefringent and polychromatic. Next. Next nice. Okay. Okay, you see. And others which are with the green circle or shining white, or non-birefringent at all. So at this point, we have to distinguish between crystals due to acid uric or cysteine. Is it possible that the same patient has two types of crystals, one due to cysteine and the other one due to uric acid crystals? Of course, we know that in medicine, everything impossible is possible. But this patient, we know that he underwent renal transplantation because he had a vasculitis, not cystinuria. So at this point, it was difficult to us to say which crystals these were. So at this point, what could we do? The only thing we could do is to filter the urine and to perform infrared spectroscopy. And you know what infrared spectroscopy told us? Next slide. Next slide. Infrared spectroscopy said that those crystals belong where due to sulfamethoxazole hydrochloride, which is the main component of cotrimoxazole, which is a very commonly used antibacterial agent. At this point, next slide, we went through the clinical notes of the patient, and we found that, in fact, the patient was under treatment with anti-rejection drugs plus omeprazole, but he was also treated with cotrimoxazole, which contain our crystals, sulfamethoxazole. The posology of this drug has been increased a few days before the finding of Crystalluria for clinical reasons, which I don't want to specify. Next slide. At this point, so we came to the conclusion that those crystals were due to sulfamethoxazole. And going through the literature, we found that other investigators have described in sulfamethoxazole crystals. The from 1978 to 2018, here Castiglione in 2018, okay? And we found all authors published described just one patient, but Castiglione from Liège, who described 7 patients, all investigated with infrared spectroscopy. Urine pH ranged from 5 to 6.5. Also, the morphology was very variable. From coffin leads and rosette to shocks of wheat, hexagons, and variables, 7 different shapes. Some of them were birefringent. In other cases, birefringence was not evaluated, which is incorrect. Infrared spectroscopy was done in only 3 of 6 papers, and some patients might had acute kidney injury, while other patients, like the patient we have described, did not have any clinical manifestation. Next slide. So take-home message. We would not have identified these crystals if our microscope had not been equipped with filters for polarized light. So the first take-home message is that if you don't have polarized light filters, you cannot investigate, and I stressing this fact because it is very important. We cannot investigate and identify in a correct way crystals without polarized light. This is the most important point of all this presentation. Second, sulfamethoxazole can cause the precipitation of crystals, which may have a wide spectrum of morphologies, from coffin lid to hexagons, and may be associated with acute kidney injury. Sulfamethoxazole crystalluria may occur in the presence of high doses of the drug, hypoalbuminemia, hypovolemia, dehydration, and urine pH from 5 to 6.56. Next slide. 6.5, sorry. Next slide. We published this case report again in Clinica Chimica Acta in 2015. How to identify sulfamethoxazole crystalluria. Next slide. Thank you for your attention. I finished. Wow. Do we have questions? Questions and answers. Four participants. Okay, let's go on. Clap. Okay, clap, clap, clap. Thank you.
I have a question.
Sí,
I have a question.
Yes.
Muchas gracias a usted.
Okay, I need to know if is there that time important for working all about the crystals analysis, because in the place that I work, we used to work with the sediment, with a urinary sediment, in about 3 or 4 hours. And I don't know if that, well, I know that that is not right, that is not correct, but is there a time, a specific time for working with this?
Oh, listen, this is a very good question. So the ideal situation would be the patient produces the urine and you go through the urine in the next 10 minutes. But of course, this cannot be done, especially nowadays. For instance, here in Italy, now there is the tendency to centralize labs in order to save money. No? And there is, for instance, an hospital in the north of Italy, in the town of Modena, in which every day there are 1,500 urine sediment to be analyzed, which is done through, of course, automated instruments, okay? So in few hours, all the 1,500 urine samples can be examined. But the problem is that all these samples come from different areas, geographical areas, villages, towns, small villages, etc., which means that the urine is collected at 7 o'clock and arrives in the lab at 11, 12 o'clock, etc., etc. And we have the same problem in our lab. We collect the urine. We ask the patient to produce the second urine of the morning. Then we start analyzing the urine at about 11 o'clock. Of course, this delay, this interval may cause some changes, but it is evident that it is not possible for labs with the organization which we have in our labs nowadays, that the patient gives the urine, produces the urine at 8 o'clock, and you can look the urine at 8:30. This would be ideal, but it's not real, practical. It's not a reality. So what is important is, the message is, the shorter the interval between micturition and urine collection, the better it is. But this interval, the length of this interval, of course, depends on the number of samples we have to examine, and the organization of which is working in each laboratory. Okay.
Thanks.
Okay, there is the possibility to use preservatives, but unfortunately preservatives, as I said before, they may change the pH of the urine, which may cause, for instance, the dissolution of CAS, can cause the lysis of red blood cells, white blood cells, or can cause the precipitation of some crystals, or the dilution of other crystals. So, and other possibility is to put the samples in the refrigerator, but the refrigerator can cause the precipitation of phosphate or urate. So the ideal thing is to identify the shorter time possible in your lab and to use it for all samples. That's it. Oh, in Mexico are photos of some daisy-like crystals. This is interesting. Vaterite, calcium carbonate variant, vaterite. Okay, do you have other questions? Omeprazole. I know nothing about Crystalluria due to omeprazole. We can look in PubMed tomorrow. Okay. So thank you for your kind attention. Okay. Okay. I wait the letter with photos of daisy like, I imagine, or omeprazole. Okay. Thank you very much indeed to everybody. Thank you, Roberto. Grazie Fiorella. A presto. Fiorella Anguileri from Chile. Muchas gracias, doctor. Okay, buenas noches a todos y a todas.
Thank you, doctor. From Peru.
Because for you it's afternoon. Here is 2:50. Is almost night. Okay.
Yes, equal from Peru.
Okay, thank you. Bye.
Gracias, profesor.
Gracias a usted. A la próxima.
Le esperamos en Sudamérica el 2022.
Speriamo, se il Covid ce lo permette, vengo di sicuro. Mi farebbe molto piacere. Va bene?
Grazie, professor.
Grazie a
Hasta
te.
pronto.
Arrivederci. Buon pomeriggio.
Arrivederci.
Buon pomeriggio.
Buon pomeriggio.
Agradecemos a todos los participantes por acompañarnos hasta esta hora. Bueno, a los 200 participantes que aún continúan aquí, les avisamos que el 2022 lanzaremos la guía de Uranálisis, la guía para la comunidad habla hispana del Instituto de Estandarización en Laboratorio Clínico del Perú. La publicación será en noviembre del 2022. A todos los participantes que nos han ido acompañando desde los cursos anteriores, bueno, ya la mayoría tenía presente en los avances que estamos realizando con referencia a esta guía. El 2020 logramos publicar como Instituto de Estandarización en Laboratorio Clínico del Perú el libro del ABC de la calidad en laboratorio clínico, y este año 2021 hemos logrado publicar el libro Validación y Verificación Básica de Métodos, cuarta edición en español, de James Westgard. Para el siguiente año tenemos planificado el lanzamiento de la guía de estandarización en uranálisis. Para ello tenemos una dinámica con todos ustedes los participantes. Las inscripciones para este curso de Uranálisis del 2022, que se va a realizar en noviembre de 2022, va a ser de la siguiente manera. Para poder realizar el evento de manera presencial, solo se va a realizar en el país que cuente con mayor inscritos hasta el 15 de diciembre de este año. Entonces podrían comunicarse con las personas que se han inscrito a este curso, cada uno en su país. Ejemplo, en República Dominicana, con el licenciado Juan Apolinar Céspedes. En el país El Salvador, con la licenciada Cecilia. En México, están ahí, la mayoría se han inscrito con EduLab. Y otros participantes con el licenciado, con el químico Eduardo Flores Ramírez o Eduardo Ramírez, también con el químico Daniel Naranjo y también con el químico Giovanni. En el país de Bolivia, se pueden inscribir directamente en la sede del Instituto de Estandarización de Bolivia con la doctora Mónica Larrea, o también en el Colegio de Cochabamba, con los mismos integrantes del grupo de logística del Colegio de Cochabamba. Y en Chile con el tecnólogo médico Diego Gómez. En el país de Colombia con la doctora Yuri Rodríguez. Así que el país donde se va a realizar el curso presencial del 2022 va a depender del país que tenga mayor inscritos hasta diciembre de este año. O sea, solo hasta diciembre de este año se va a contabilizar los inscritos de cada país. Ejemplo, si es que en México tuviera más inscritos, se realizará el curso presencial en México, y para todos los demás países el curso será como lo hemos estado haciendo estos años, de manera virtual por transmisión online. O si ganara otro país, por ejemplo, también vemos mucha participación de Chile, también de Bolivia, también de Perú. Entonces, si hubiera más inscritos para el curso del 2022 hasta el 15 de diciembre, vamos a anunciar el 20 de diciembre el país ganador. Hasta pronto con todos ustedes. Los esperamos en el curso del 2022. Estandarización en Uranálisis. Para los que desean que se repita el encargado en Bolivia, con la doctora Mónica Larrea. Ella es la encargada de la sede del Instituto de Estandarización en Bolivia. Contamos con una oficina del Instituto de Estandarización y Laboratorio Clínico del Perú, ahí en Bolivia. Y los que se inscribieron con el Colegio de Cochabamba también podrían volver a inscribirse para el curso del 2022 con el Colegio de Cochabamba. Pueden comunicarse ahí directamente con los mismos números del colegio. Si es que se inscribieron directamente con Perú, de otros países, por ejemplo, los participantes de Ecuador, de Costa Rica, igual podrían inscribirse directamente a los números de WhatsApp del Instituto de Estandarización y Laboratorio Clínico del Perú. En el Facebook estamos como IELC del Perú. También contamos con un grupo de Telegram con más de 2,000 participantes, donde solamente compartimos casos de uranálisis. Ejemplo, si alguien desconoce la identificación de alguna estructura, le toman una fotografía y nos comparten a ese grupo de Telegram, y todos los demás expositores o los que están ahí integrantes también vamos comentando ahí la respuesta de qué estructura podría ser. Eso sí, rogamos que nos compartan la fotografía con datos adicionales como los resultados de la densidad, el pH y datos del paciente, ¿no? Si tiene alguna enfermedad o algunos datos clínicos del paciente. Bueno, estamos muy agradecidos con todos ustedes. Los que se inscribieron al curso de apertura de laboratorios clínicos o implementación de laboratorios clínicos va a ser, si no me equivoco, la primera semana de diciembre. Igual también por Zoom, va a ser 2 días. Y pueden solicitar mayor información de este curso directamente al WhatsApp del instituto. el costo del curso de apertura de laboratorios clínicos en base a normas peruanas e internacionales. Para Perú el costo es de 30 soles y para otros países el costo es de $10. Gracias con todos y que tengan un super año. Hasta pronto.